Hello, we're going to start a lecture on pain. This is for PN100. Um, First thing I want to tell you is pain is what the patient says the pain is. There is a pain guru who has a theory. Her name is McAfee, and she very much believes that it is a totally subjective experience that is dependent on what's going on with the patient. So some people will say their pain is a level 2 and they have a limb falling off. And other people will say they have number 10 pain and they're jumping up and down. And so it just depends. Pain is what the patient says the pain is. And as a provider, you cannot judge. Um, You can have pain that is classified as acute or chronic. Again, if you are in an accident and you break an arm or a leg, that's acute pain. Some people have chronic pain, maybe chronic back pain. Maybe they have sickle cell anemia, so they're always in some sort of pain. Rheumatoid arthritis, that would also be a kind of chronic pain. There is pain that's associated with cancer that is totally different than any other kind of pain. Pain can also be associated with non-cancerous conditions, of course, illness, disease, injury, surgery, diagnostic procedures. When people have resolved pain that they just can't get a hold of, it causes huge problems, physiologically, of course, psychologically, and then if they're get to the point where they're unable to work, then it can cause financial consequences. It can ruin families. Very, very important that we handle people's pain. It can disable a person. It can debilitate them. And pain in general distresses more people than any other single disease. Um, think about if you've ever had surgery or, like I said, a broken arm or anything like that. You don't even want to breathe. Um, and then if you don't and that's not treated, then it just goes into more serious problems. And if that pain was never relieved, imagine dealing with that on a day-to-day basis. Very, very hard. Um, Sometimes relieving pain does not mean you're going to cure the disease. Again, when you're talking about chronic illnesses like rheumatoid arthritis, sickle cell anemia, chronic back pain, you might not ever cure what's going on with them, but maybe you can come up with some kind of cocktail that will help the patient. Never assume that there's not pain just because there isn't some tumor or lump or broken bone. Some people have what they call idiopathic pain, which is pain that has no source at all. There are three things to think about when you're talking about pain. The perception of the pain, the threshold, and the tolerance. Pain perception is an awareness or a feeling of the sensation of pain. So it's something like, with pain perception, you are aware of the feeling or the sensation of pain. Again, if you break your arm, you're going to know it hurts. If you lift something wrong and your back starts to hurt, that's the pain perception, that you know it's there. It's probably a negative feeling. Most people are not into having pain, and you have systems in your brain, neurological systems, the cortical system and the limbic system, and those structures get involved because they try to protect your body when there is a pain issue involved. Then there's the threshold, and this is different for every person because pain is so individual. For some people, they can be in horrible pain and still function, still go to work, still complete their activities of daily living. And then there's other people who just really struggle with even minor pain, and it can possibly take them down. And then there's pain tolerance, and how long can you take it before you need to do something about it? Some people will say if their pain gets to a number 2 or 3, they need to be medicated. Other people will say, well, I don't need any medication until I absolutely can't function. Um, in your book, there is a chart, and it's called the Myths and Facts of Pain. And that is a really good document because it tells you some interesting things about pain that you might have heard the opposite on. So make sure that you look that up in your textbook. There are 3 components to pain. Stimulus is the physical or mental part of the pain. Sensation is the body actually saying it hurts. And the reaction is how do you handle it. You break your arm, you're going to immobilize your arm. You have a headache, you're probably going to lay down in the dark. Everybody's reaction, again, is a little bit different depending on the kind of pain that they have. We can also classify pain. There's nociceptive pain, and that has 3 different sections to it. Visceral pain, which comes from internal organs. So abdominal pain from diverticulitis would be one. An appendix that's rupturing, gastritis, anything like that. And then somatic pain arises from the skin, the muscles, and the joints. So a surgical incision, a broken bone, anything like that. Usually pain is closely related to the damage that's in the body. And so again, if you break your arm, you're probably going to be in number 10 pain in that arm. If you have surgery where the incision is, again, it's going to, for a couple of days, be number 10. And then as the body heals, that pain should be relieved. The problem is when that pain is not relieved. There's also neuropathic pain, and this comes from the nervous system. And you'll see this a lot in diabetic patients who, it's kind of weird because they're actually losing nerve tissue to their peripheral hands, feet, and in the process of them losing that, it is quite painful. Shingles is another example of neuropathic pain, and they'll say it's either burning, electrical shock-like, sometimes it's aching, and then with diabetics especially, eventually they get to the point where they don't feel their extremities at all. So, like I said before, pain is what the patient says the pain is. And you'll have in your career, I'm sure you'll have what we call frequent flyers, people who come in for pain management, and they're walking and they're talking and they're, as pleasant as they can be, and they come up to the nurse's station and they say, it's time for more morphine, it's been 2 hours, and they're just as perky as they can be. And you say, what is your pain level? And they'll say, it's a number 10. And you kind of look at him and you think, really? Because if I was in number 10 pain, I'd be racked out on the bed, not able to open my eyes, curled up in a fetal position. It is very, very hard not to judge people for how they regulate their pain. But just always remember, pain is what the patient says the pain is. There are tons and tons of medications on the market for pain management. Narcotics, as you know, are a big issue right now. Fear of addiction, all the other problems narcotics cause the body. We have to be very, very careful when we give medications that they are appropriate. And you have to remember that when a patient is really in pain, postoperative pain is the best example I can give, traumatic pain. They will not get addicted to narcotics if they're taking their narcotics accurately and adequately. So let's say you have a patient who's post-op, I don't know, some sort of abdominal surgery. When they first come out of surgery, they might have high-level narcotics ordered. They might even have a PCA pump or something where they're getting Narcs IV. And that's okay because that pain is significant. But 5 days later, if they're still requesting that medication instead of something like ibuprofen or even Percocet down the line of drugs, then you do risk the patient becoming addicted. Cost for long-term, especially chronic pain patients, is very high. There isn't a lot of access to pain specialists, and again, with the overuse of narcotics, adequate pain management clinics are really having a hard time. There are many barriers to pain management that unfortunately hurt patients like cancer patients. At the end of life, almost 50% of cancer patients have horrific pain. Um, AIDS patients have horrible issues with pain that sometimes go untreated and undiagnosed, and I'm going to say based a lot on judgment of how they got their disease. Also, minorities on assistance programs, there's all kinds of research out there that they have a hard time getting adequate pain management. So I guess pain is being judged by the color of someone's skin. And how absolutely offensive is that in a profession where we are supposed to um, applaud cultural diversity? In the basic lifespan, those at the highest risk for not being medicated or treated properly for pain are children and elderly people, people who are cognitively impaired because they don't have the ability to tell them where they hurt and how bad it hurts, clients who deny pain. This happens a lot in the plain community in this area. You know, a mother will just have a C-section. She'll come back, so she's had major abdominal surgery, and because of their culture, she'll say she isn't in pain. That is really unfortunate because there's no way to have your abdomen opened from one side to the other and not have pain. If you are in a facility where everyone speaks English and you don't, it is very hard to find appropriate medication for pain. Some cultures react to pain differently. They're not good at telling you what the pain is. And then, of course, if you have a history of an addictive disease, it's very hard to be properly treated for pain because there are so many built-up tolerances, judgments. There are so many paradigms involved in a person with the history of an addiction. So I like this slide because it talks about the clock watcher. And this is, like I said before, it's the patient who comes up to you with their IV pole. They're very perky and they tell you it's now time for their morphine. And you really wonder why. Again, when you have those patients, pain is what the patient says the pain is, and you medicate them as prescribed. Certainly in a prescriptive situation, in a hospital especially, there will be levels. If the patient has number 10 pain, we'll use morphine. If they have 6 to 8, we'll use a Percocet. If they have 5 or below, we'll try an NSAID. So you really want to medicate the person as prescribed with no judgment attached. Here are some terms that are important to know. Tolerance is very important when you're dealing especially with a patient who has a history of drug use or abuse, because they have built up a tolerance and they need a lot more medication to relieve their pain. This is very hard when a frequent drug user has a traumatic event, a broken bone, a surgery, because it is almost impossible to make that patient comfortable, and it's just really hard for them. True addiction. This talks right here about physical dependence. It's the adaptation to a drug that produces a withdrawal syndrome. Abrupt cessation, rapid dose reduction, decreasing blood levels of the drug, or administration of an antagonist can really cause these people harm. True addiction is a psychological use of a drug that then becomes physiological, and very dangerous for that patient. I'm going to quit in this video now. This is video 1, and we will move on. In the second video, we will start talking about addiction as a problem.